Well, hello everyone, and welcome to this Parkinson's webinar, the first of 2023. My name is Diga Hastus, and I'm the head of the Parkinson's Academy and the chair for this afternoon. Before we start, I would like to thank our sponsor Zangon in supporting this learning. The session will start with a discussion between Archie and Louise looking at the do's and don'ts of a Parkinson's neuro assessment. So, without any further delay, let me hand you over to Archie to start this afternoon session. Archie.
Thanks, Diga. That's great. So Louise and I are going to do a little kind of tag team job with across a range of topics. I think, Louise, isn't that right?
Yes.
We had a nice discussion about this last week, tried to think about how we could make it sort of interactive and interesting. I think it's we're going to spare everybody too many slides, or any slides actually.
Yes.
I'm saying too many. But what I wanted to do was just really have a conversation, a sort of like a back and forth between Louise and myself, because there are quite a lot of kind of difficult issues around referral into Parkinson's care and about assessment. And I don't know, what do you think, Louise? I feel like we could simplify this for people a bit just by kind of talking through what's important to us from our end.
Most definitely. So if we give them tips of what we want in secondary care to be able to make the appropriate diagnosis and how soon we need to see patients.
Yeah. So, I mean, with that in mind, then I was thinking to myself, I mean, I'm on call this week. I have to triage a lot of referrals. We've got 300 to triage this week into neurology. And so like you spend a lot of time reading referral letters from all over the place. And like there's something about a really amazing letter, like they stand out in terms of their content and their tone and what they're asking, their questions they're asking. And it just makes the job of triaging somebody into the right bit of the care pathway much, much easier. And equally, there are certain letters like "please see and do the needful" that maybe don't don't give us as much to work with. So, like, if you're sitting looking at a number of referral letters, Louise, like, what constitutes like the perfect referral to you as an experienced Parkinson's clinician?
Well, obviously the GP is suspecting, hopefully, Parkinson's. So we would like to know the history. So what is the history of the symptoms? Is it been long and insidious, or has it been very short? We know nothing is an emergency in Parkinson's. There's nothing that suddenly happens. So we want to be able to rule out if it's an essential tremor or Parkinson's tremor. So do they really need to describe a tremor? That's always a difficult question, because sometimes it puts you off, and do you actually want to think then Parkinson's? Because we know there's a percentage of patients that never have tremor. So we always want to know if the symptoms have started one-sided. And we want actually the GP to look at the patient walking into the room. Have they slowed down? Have they got lack of arm movement, and are they dragging their leg? And the one thing I always wonder is, do anybody look at a patient and see, are they hugging the doorway as they walk in through the room?
Yeah.
Are they struggling to walk into the room? So have they got start hesitation? And are the family or the spouse that's with them is saying they've slowed down, they're much slower than you or I? And when you're in the clinic room with them, has the spouse taken over all the talking because the patient is slow and not interacting? And when you're trying to take their coat off or put it back on, can they actually do it themselves? And can they sit to stand? I know that's an awful lot of jumbled things, but there's a lot more information in that type of history than actually saying they've got a tremor and have they got slowness and globally slow rather than specific symptoms. Does that make sense?
It does. I mean, I think, I sometimes think, like, when I write a clinic letter from a Parkinson's review appointment, I always I have like the first paragraph is from a motor perspective, and then the next paragraph is like a non-motor perspective. And so, like, I think what you're sort of getting at there probably is that just that observation from the waiting room into the consulting room, that's all motor, isn't it?
Yeah.
And there's
And
like,
that would only take a few seconds because it's actually observation without asking a question after you've done the when they go to do any type of neurological assessment on them. So they'll have to do some assessment, won't they? Because that's what you do when you assess a patient in your clinic room.
I mean, I think one of the disadvantages, I think, in primary care for a lot of primary cares, I mean, they've just introduced this in our outpatient room, is you can summon the patient to your examination room, which I don't use that because I'd still go down and call the name, and you see, how does somebody get out of a chair, and like that walk, how do they turn a corner, how do they come up the corridor, and I think a lot of the GP practices maybe aren't set up like that, and so you get pinged into the room, don't you? I think a lot of that early information is lost. I don't know how to capture that. If that's your system, you don't know what's coming in to see you.
No,
you're not always going to go out and go, this is one I have to go out and find. But I think that is that people are. I think GPs are. I feel like they're at a big disadvantage in a movement disorder referral if the patient has come through the door and sat down without them seeing all those extra little bits happening.
Yeah, and they also need to ask about some non-motor symptoms, which would be key for us in a letter. So you want to ask about a sense of smell.
Right.
How long have they noticed their symptoms? And some sleep disturbance, if there's any REM sleep behavior disorder.
So can you just explain what that sounds like from a like RB, like REM sleep behavior? We're familiar that as a symptom, like an early warning of conditions like Parkinson's and dementia with Lewy bodies and multiple system atrophy. Anything that's got like a sort of Lewy body synuclein thing, RBD is this big kind of red flag. But like, what does that actually sound like in a history?
Okay, so what you're asking, what is sleep like? Do they, if they're a husband and wife in the room, or if they've got a partner, do they still sleep in the same bedroom, or has the partner moved out because they've either attacked them in their sleep, or they're talking, or they're getting in and out of bed, and they're very they're enacting their dreams. So I tend to say to a patient, tell me, do you have any dreams or nightmares? If the partner is there, do they talk in their sleep? Oh gosh, they've attacked me. So I try to explain what RBD is and what REM sleep is and non-REM sleep. Yeah. And they can enact their dream every 90 minutes throughout the night. So they fall asleep, deep sleep, very deep sleep, REM sleep. And when you're supposed to be totally atonic, the only thing that moves is your eyes behind your eyelids. But when you're in REM sleep, RBD, you start enacting what you're dreaming. So you could be, if you were scoring a goal for England in the World Cup.
And I think this falling out of bed, I don't know whether you find this, but quite a lot of the T-side Parkinson's patients, male ones anyway, they're saving a penalty.
Yes.
And they dive out of bed and end up on the floor. And like my kids fall out of bed all the time. But I think if you start falling out of bed and you've got some sort of motor disorder, like it's going to, the question is query Parkinson's, and there's that sort of autonomic disturbance with sense of smell or bladder or bowel dysfunction, or that autonomic sleep thing, and the people are falling out of bed. I think that's quite suggestive, isn't it? That you're going to be, if I was triaging that, I'd be like, uh-oh.
Yes, most definitely.
That's not a benign tremor.
Yes.
Yeah. What about so I suppose like there's a motor bit, which is just seeing that patient come into the room, having a look at them walking, arm swing, facial expression, that sort of that side of things. There's the non-motor stuff that you've hinted at. Are there any kind of like killer questions around? I was thinking about motor stuff, because I think it's like you're interested in, to diagnose Parkinson's, you need like bradykinesia, which is a clinical sign, which is actually quite difficult to examine confidently, I think. We'll come on to that in a minute, I think. But are there, like, what does bradykinesia sound like in a history? And are there any like sort of top tip killer questions that you ask to try and extract that?
I ask if they can turn over in bed, and are they able, not always to get out of bed, but be able to get their legs into bed, and do they need support to turn over? So that's quite key, because the majority of people can turn over in bed, can't they? But our early Parkinson's patients can't. And very often they're always asking, I'm buying a new mattress, because they're never comfortable in bed. And they're not fidgety. And when they're sitting in front of you then in a clinic setting, they don't fidget. Like, I'm a very fidgety person. If I suddenly became still, you'd all start thinking there was something wrong with me.
But I think your screen had frozen.
Yeah. We always ask a sense of smell. I don't know if there's time. Well, I suppose there is time, but that's, again, subjective.
Yeah.
And I ask them, if it's been a rainy day, can they still wipe their feet on the mat, because they haven't got that fluidity of movement any longer.
I love that question. I never asked that question. That's a great question. This turning over in bed thing, I think sometimes people look at you like you're psychic.
Yes.
Or have been creeping about in dead of night, peering through their windows. So they're like, how do you know that? Can't turn over in bed. It's like this. I love that. It's such a revealing question. So if I got a letter from a GP and it had, could you see this, like a 2-year history of progressive problems, and they're slowing down and they're shuffling and there's loss of arm swing and there's a bit of a tremor, but on top of that, there's this sort of autonomic vibe and these kind of weird little oddities around sleep and turning over. I don't. It's sort of diagnosis kind of made in that letter, isn't it?
Yes. Yeah. And I suppose the other one thing is, can they still do their buttons and zips? Because that's very difficult for people as well.
Yes. Although I think there's a health warning with that question, maybe if you're trying to differentiate a benign essential dystonic tremor from a Parkinson's tremor, because I think that both of those things make activity to daily living really difficult, but in different ways, so that for a Parkinson's tremor should largely go away
when they're doing something.
When they're doing stuff. So it's more that loss of dexterity.
Yes.
In the ADLs that you're trying to get at, I think, in that, whereas if the tremor ramps up on action, and if there's a head tremor, I always just I'll still see the patient if you're right, they've got a head tremor, obviously, but I know I'm not going to be seeing Parkinson's if they've got a head tremor.
Definitely.
Yeah, that's great. That's really helpful, because I think hopefully for the people listening, then, it's just, if you're structuring your referral letter, maybe like the way we structure our clinic letters about like motor and non-motor and day-to-day impact, maybe a referral letter that talked a little bit to the motor stuff, had that time to flesh out a wee bit of that sort of funny non-motor, pre-motor, almost the stuff that's 5 years before the motor, as it's sort of, as the conditions sneaking up on people. That's almost like I dream of that letter.
Yes.
So rarely is it seen, but who knows? After this seminar, maybe
you never know.
Yeah,
you never know.
Okay. I mean, I suppose if all else fails, sometimes you do actually have to examine the patient, don't you?
Yes.
Which is maybe where, like, if we swapped it round, maybe and spent a wee bit of time just talking about like how you actually do that, because it's I think every GP's worst nightmare.
So really what I want to ask you then is, what would be your 3 top areas from a neuro exam that you can do in a 10-minute GP consultation? So what would you be looking for in somebody's gait? Because you would still see them coming into the room, even if it's not down the corridor. And depending on who is doing the referral, how would they describe the walk?
Yeah, I think that's a great question, Louise, because I think it's not just doing the test, it's like what then gets written down. So I think, like, I don't really think that it's that important to examine, like I said, a heresy thing for a neurologist to say, but if you've only got 10 minutes and you had to choose between an extra 3 or 4 minutes on discussing non-motor symptoms and drilling down into that, I'd really recommend people did that. Because, like, at the bottom line, your referral is like, will you see this patient? How quickly do you need to see this patient? And I'll mostly just do the examination and mostly ignore what's written down, because I know I'm going to repeat it anyway.
Yes.
But that's the various neurologists, many of whom aren't even dead yet, will be turning in their graves at the thought of recommending to not So we better do some. So yeah, so I think, we sort of hinted a wee bit about like doing a gait assessment. There aren't many neurological gaits actually. And I think most clinicians would be familiar with the Parkinsonian gait, which is like slightly forward, center of gravity, festination, that sort of sense that the feet get faster and faster. And the James Parkinson's description of one of his original patients running from lamppost to lamppost through London and stopping at each lamppost because they were just getting ahead of themselves. So that's like that description, hundreds of years old as it is still like amazingly vibrant. So if you see that, you sort of know what you're doing. Arm swing is just very important. I saw a guy yesterday in clinic, his tests are normal and his investigations are normal, but I'm sure he's got Parkinson's, and he just does not swing his arm, and it's very stiff. So I think that's good. I think you're right, that sort of hesitancy coming through a doorway, pretty okay walking, and then change direction and the steps become smaller. And I think I talk about gait ignition failure, gait hesitancy, small steps on turning, freezing in doorways, reduction in arm swing. I don't need any fancy chit chat with it either. Okay. And I think just say, describe it as you see it, and that's much easier.
Okay.
I think the tremor bit, which is, I mean, I know that there's a very frequent typo in letters where it says the patient has an intentional tremor.
Yes.
Which I know is just like it's just a typo thing. And some of the typos that come out of my voice recognition system at work are epic and embarrassing. But obviously, I think so obviously intentional tremor is that's just a deliberate tremor. So that's not what really we're expecting. I think intention tremor is a much abused term. So I don't know whether it's going to work with my camera or not, but anyway, I was seeing a patient on the neurology ward this morning who's got a cerebellar syndrome. She's ataxic, broad-based gait, looks like she's drunk, slurred speech, eye movements all over the place. And when she's reaching out to a target, as she gets to the target, she wobbles a bit. So she's inaccurate at the point of intention of touching the target. And she overshoots a little bit. That's called dysmetria. And so if you're saying intention tremor, what you're really saying to a neurologist is, I think this patient has a cerebellar ataxia. And with that should come broad-based slurred speech, nystagmus, and all the other stuff. And that's a completely different condition or group of conditions. So patients with Parkinson's never have an intention tremor. What they have largely is a resting tremor, and it should be coarse and asymmetrical, often unilateral, and you should almost be able to count the oscillations per second, like 3-4 oscillations per second. And that's a very characteristic kind of resting tremor. And the other a great tip that I got taught years ago by Professor Byrne, which is, I think is incredibly helpful, is, so you sort of see this resting tremor. And if you want to look at that, I mean, you're better off observing it out of the corner of your eye during history taking, because you'll see it then. And if you chuck a spotlight on it, you modify it almost instantly. But if you're going to do it like the arms relaxed on the lap, I can't do it. I can't get my knees that high. I'll tip over back. But yeah, so arms on the knees, thumbs like that, and then what you just wait, and the tremor will be there. What David Byrne told me years and years ago was look for this thing called a re-emergent tremor. So resting tremor goes away, so it's on the lap, you'd see the tremor, arms outstretched, tremor goes. And then if you're patient, and sometimes you have to be quite patient, if you just wait a little while and chat to the patient, and if they can hold their arms out, then it starts to come back. And that sense of like it's there, it's gone, and it reemerges, that's really, really characteristic of a Parkinsonian syndrome. And it's usually idiopathic Parkinson's disease. I think I've scarcely ever seen a re-emergent tremor in anything apart from Parkinson's disease. So I think if I was kind of restricting to a few things, I'd say, yes, that sort of gait thing we've hinted at, just that tremor and that vibe of like what happens as the hand moves and does it come back. I think bradykinesia is hellishly tricky. really tricky. If somebody's weak, so what you're talking about, bradykinesia, I always got this wrong for a long time, embarrassingly long time. I thought it was slow movement because I did Greek at school, and brados is slowness. That means slow. All right. So and there's something about the movement is slow. That's right. But it's a decrement in the amplitude over time. And the thing in the history that gives you bradykinesia, if you think about writing getting smaller over the page, it's that sort of amplitude of the loops of text get closer together. Okay, so micrographia, which for some reason sticks in everybody's head as a symptom of Parkinson's, is a form of bradykinesia, kind of. So what you're looking for with either quacky ducks or spinny, these are my light bulb moment, utility dance maneuvers. Those are the things where you see bradykinesia, and I do that one, and I don't know whether you do different, Louise. Actually, those are all I do. I
always do that one.
Yeah.
But I often look at their feet, because sometimes if they've got arthritic hands or they can't hold their hands up, I will ask them to tap their feet, and because the length of their feet is that much longer, you can see bradykinesia in their feet.
That's good. Yeah, I see. I should come to these webinars more often, Daiga, because I've after 14 years as a movement disorder consultant, it's always a teachable moment. Yeah, and I think my other things I got taught were patients can cue off the other hand.
Yes.
And people can cue off you. So if you show people what to do, you must then stop and then watch what happens. And I like this one as well, because sometimes this one is like, it's a wee bit hard to interpret, but if people can get stuck rotating their wrist, that's very abnormal. And you should look for asymmetry. Yeah. Because that's quite crucial. The one thing I think that people find very difficult is tone.
Yes.
And I was just saying, this may not be a resource that everybody finds terribly useful, but we have I'll do a quick screen share. So we have a teaching site for our medical students in Teesside called Tees Neuro. And on there, there is a little how to examine section, which is a bit, it still needs bulked out a bit, but there's a section on tone. And there's a little bit about the difference between rigidity and spasticity, which we don't really want to go into today. There's a video of how to examine a patient for rigidity and how that contrasts with spasticity. And these are my patients who've given me permission to show you these videos, and they'd be very happy for you to look at them. And there's other sort of resources on that website. So in addition to the stuff from the masterclass, which we're going to link you to, if you want to have a look at sort of videos of like how to examine stuff like that, maybe that's one way to do that. And that's all you need to do. It's actually relatively quick. And I wouldn't want people to spend much more than a minute or two on that, because actually it's all in the history.
Yes.
Okay. So I suppose the last little bit that we wanted to talk about, or at least I wanted to ask you about, Louise, because our nurses are amazing, and they're incredibly busy, spinning about 15 different plates every day, like helpline, email, telephone, clinics, and in between all of that, there's the ward consults for the hospital we're based in, and the phone calls from wards all around the region about, like, we've got this patient of yours, help. So I was just wondering, like, what do wards ring you about, in terms of, like, what are the main drivers of admission and ward consultations for you as a Parkinson's nurse, Louise?
We have phone calls every day. We have a lot from ED. And I must admit, our pharmacists and our OTs are particularly helpful, because they're the ones that will contact us first. So very often a patient's coming with fall and a fracture to orthopedics. Very frequently it's a pneumonia, a chest infection, or a UTI, or there's social issues, especially with the state of care at the moment, and the social care staff members are going in and think there's something slightly changed with a patient. But once they've left ED and they've gone up to a ward, it's very often they feel that their swallow isn't as good. They haven't actually contacted speech and language, which we advise them to do first. And can we switch them to a reticketing patch? Well, the answer is always no, because I don't know why I know reticketing patch is particularly helpful in certain areas, but it seems to be the most common thing that ward staff want to reach for, as opposed to continuing with the normal regime of the patient, or switching from a capsule to dispersible so they can swallow a little better. They don't even go for an NG2 first. They always want to go for a reticketing patch. So very often we may have a patient who may be nil by mouth or has got a fluctuating swallow and has some delirium. They've decided they can't swallow and they want to put them on a patch. They haven't looked at the history. They don't really realise there's cognitive impairment, or they may have a Lewy body dementia with Parkinsonism, and we don't want them on a reticketing patch. We'd rather give them dispersible Madapar. So it's that type of patient we have phone calls off every day. We don't go and see all our patients. We give an awful lot of telephone advice, especially if somebody has come in with a urine infection. We don't want any medication changed, because we want them to treat the UTI first, and then we'll see them if they become deconditioned after their infection or something else has deteriorated with their Parkinson's.
I think that's really good. I mean, I think I don't know what the calorific content of a reticketing patch is, but I think if you eat them, you don't get a lot of sustenance. And
No, exactly.
I sort of feel a little bit like you go, okay, so you've dealt with the dopamine receptor state, sort of, but has my patient been fed or watered?
That's the most important thing.
And I feel like, yeah, I agree with you. I think reticketing patches, they have a role.
Yes.
For sure. Particularly, I think, I don't know, like sort of perioperative kind of stuff in a younger patient without cognitive issues. It definitely got a role if you're going to have gastric surgery, or like, you know, going to be ill by mouth for a period of time. Like, so, you know, they're helpful. But if you wouldn't stick a 78-year-old lady with cognitive impairment on Rapinol, high-dose Rapinol,
no,
straight away, then you probably shouldn't be reaching for reticketing either in that way.
No. And whenever it's usually the pharmacist or the ward doctor ring, when they've tried to go to the optimal calculator and they put them on a big dose, I say go low and slow. You've got a patient who has never had a dopamine agonist ever. They're naive. Put them on 2 milligrams, and if you never put them on anything higher until their swallow come back, that is fine. But we don't want to go on 8 and 16. But you may come in on a Monday morning after a weekend and have to see a patient on a huge dose of reticketing patch, and now they're delirious and psychotic, and they're being special, so they're using more resources purely by inappropriate use of medication.
And I mean, I've definitely been at the other end of not wanting to put an NG in because patients confused, they're pulling NGs out. I mean, it is an imperfect situation, and you worry, I suppose, a little bit about, like, once the NG goes in, you know, ethically, can you then take it out? And like, are you going to be back to square one in 2 weeks' time? But I think there's an argument, particularly if there's a reversible, like an UTI or a proven UTI, I should say, or a definite chest infection, a parexial confused patient. I think there probably is an argument for trying to make sure that they're hydrated, got nutrition, and their normal levodopa medications, rather than swapping them onto an agonist.
Most definitely. And another tip we need to keep on telling the wards is, as soon as their underlying infection has been treated, get them out. Don't leave them in bed, because they become deconditioned so quickly, and then their length of stay is so much longer than any other patient.
Yeah. I mean, what are the things that you don't go and see, or like you don't feel you need to see?
Right, so in our area, we have a pre-assessment screening. So every patient that has planned surgery, I fill in a form and say what we can do for their medication if problem happens post-operatively. So we don't tend to see our surgical patients that are coming in for routine operations. We say use their normal regime and go on what the patient says rather than what's on the GP list, because it's not always up to date, or they may have been seen in clinic 3 weeks earlier and we've slightly adjusted their timing. So we obviously listen to what the patient and the family are saying. If somebody has come in and they have had a chest infection, there's nothing wrong with this swallow, there is no need for us to go and see them as long as they're treated for that underlying cause. Yeah.
That's good to know, isn't it? Because we do get, I mean, there's a question actually in the one of the sessions about do you need to increase levodopa if they have rigidity?
I tend not to increase tablets at all in hospital.
No.
Very often I may do a home visit once they've gone home and then review them or bring them back to clinic, but I try not to increase anything when they're inpatients. I may reduce it, especially if they're delirious.
Yeah, and I think, sometimes I feel, I don't know whether this is right or not, but I feel like their levodopa requirements in hospital often are a bit lower anyway.
Yes.
Particularly if they're in a bed and they're confused, and also, I mean, like rigidity, tremor. I mean, tremor is almost impossible to treat with medication anyway, and so the fact that the patient has symptoms of Parkinson's and signs of Parkinson's shouldn't really be a massive surprise.
No.
And it's almost a little bit like, I mean, we're all going, it's mildly off topic if you don't mind, but I get, as I also do lots of other neurology things as well, but I get letters from orthopedic surgeons touchingly and optimistically asking me sometimes if I could optimize somebody's epilepsy because they're due to have a shoulder operation and they don't want them to have a seizure after the operation that might dislocate or damage the operation. And I have to stop myself from writing letters back going, thank you so much for jogging my memory and asking me to cure the patient's epilepsy, because I've obviously forgotten to do that for the last 7 years that I've been treating. And it's like, you can't, like, so there is some stuff you just can't treat, and you can't give a patient no tremor or zero rigidity, and you're just chasing the wrong target then, and it's that's the disease. And actually, you're right. It's like, how is the patient? What do the family feel? Have there been any big changes? And how much of this is likely to be dopamine responsive? And is that the priority right now?
Yeah, because half the time when we go on the ward as nurses, we're educating them about the tremor. We've had a gent who's had DLB, he's recently passed away, but horrific tremor. And every time he was admitted, when he went into the care home, everybody rang to say, can you sort out his tremor? No, we can't. But who are we trying to sort it out for? You or the patient? The patient has lived with it for the last 6 years and coped with it. And in the beginning, understand there was very little we could do, horrendous hallucinations. But the ward staff and the care home staff just wanted the tremor treated. And half the time it's for themselves, because they think they should be doing something rather than it's for the person with the tremor.
Could I ask, Louise, there's one other thing which is like a little bee in my bonnet, because I think we're nearly out. I want to spend a wee bit of time with some of the questions. I know, I told you it would fly by. I say to our registrars often to be mindful of particularly progressive supranuclear palsy in hospitalized patients with Parkinson's. I feel like it's massively overrepresented on the wards and scarcely ever thought about. And I don't know what your experience of that is, and like, what are the clues if you're being asked, if people are ringing you, like, when do you start to think, hang on a minute, is this actually Parkinson's?
The falls, isn't it? And the backward falls, and the physio is concerned because they're trying to mobilize them, and next minute they're falling over. And it's not that getting up from a chair and falling backwards. It's actually once they walk in, they suddenly fall backwards, and they fall back just in that movement, isn't it? It's not they slump, they just go from upright, and they've got a very upright posture, and they just fall backwards. And they can tip the chair backwards. and then they shoot out of the chair like a rocket. Everything is an emergency with a patient with PSP. If you ask them to do something, they hear something with another patient, they run in to do it themselves.
Yeah. So
because they're risk takers, aren't they?
Yeah, and I think a really good tip for most clinicians would be that if you've got a patient who's got a diagnostic label of Parkinson's, which may or may not be right, but like you know, I make diagnosis of Parkinson's and then I refine the diagnosis 2 years later when I'm wrong, which happens a lot.
Well, that's the differential diagnosis, isn't it?
Yeah. And I would just say, like, if you've got patients who have had a diagnostic label of Parkinson's and are only maybe 2 or 3 years into their diagnosis and are getting repeatedly admitted to hospital, they're falling, their swallowing's off, they're on their second aspiration pneumonia of the year, their communication struggling, and there's loads of caregiver strain around this, they're freezing all the time. If it's just gate chaos, I'd say that diagnosis is probably wrong.
Yes.
Not the treatment. Because often it'll be like, you need to come and optimize the Parkinson's because this treatment, because this patient's in a terrible way. And you're like, you go along and suddenly like you realize the eyes aren't moving and the voice is different.
Yeah. And
you try and stand the patient and they're just kind of going black the whole time. And you're like, I just got this wrong. So I'd just say, like, if it's that 2-3 year kind of period and it's unraveling rapidly, that's really not typical of Parkinson's at all. And I mean, would you agree with that, Louise?
Yeah, I agree with it totally.
Yeah.
But it's not you've got the diagnosis wrong, is it? Just takes time sometimes for the symptoms to show.
Yeah, agree.
And sometimes they may respond to a little bit of levodopa in the beginning, but I suppose it's when they turn up also in our clinic in a wheelchair very quickly, because Parkinson's don't turn up in a wheelchair very quickly.
Yeah.
And it's that history of falls. And even before they come into hospital, the family has started ringing us as the nurse to say they're increasingly falls, or ED are ringing us an awful lot with our PSPs. They ring to say they've come in again with a fall.
Yeah.
And then they develop their palilalia and that type of symptom.
And then just the trajectory is just so different for that group of patients. So I just think, you know, I have, particularly with the inpatient cohort, if people are listening to this and they're looking after patients with Parkinson's or Parkinsonian disorders on their ward, just a little bit of a kind of radar moment for like, could there be something like PSP going on here? Yeah. And sometimes then when you have that thought, it becomes a lot easier to spot it.
Yeah. Yeah, of course. But sometimes you just don't pick it up for whatever reason, isn't it?
Yeah. We've had a few questions, Daiga. I mean, I don't know, is it worth us trying to look through any of these?
Yes, please. Yes, please do.
Is that okay?
You've still got 6 minutes.
Okay.
Oh gosh.
So question, some of these have been answered. All right. Who's that? All right. Okay. Yeah. So in terms of grading, there's a question about, you know, do you grade examinations so you have a baseline in comparison to monitor effectiveness of medication? I don't. Research trials do that, Kate, which is, you know, and that's grand, but like in the real world, we don't have the time. My clinic outcomes are, how are you since we last saw you?
Yeah.
Like, I mean, it's just, you wouldn't get that past the Movement Disorder Society task force at all. No. The stuff that I do, but like, that's what we'd all do really. Yeah. It's like, we're just, are you better? What's better? You know, and you just sort of get, you've got to get a sense of it. So I wouldn't bother with grading things, mild, moderate, severe, maybe. It's kind of, but that's quite a sort of subjective thing. There's a couple of questions from Nick Bryden said, we've adopted patients bringing their top 3 issues to the Parkinson's clinic rather than asking 30 or 40 questions. Do you do the same, Louise?
Yes. So if somebody comes in with a sheet of paper, I say, what are your 3 main issues today? And we'll address those. And the next time we see you, whatever else, if we haven't managed to rectify them or improve them, we'll move on for the next appointment. But it's always the top 3, because you can't deal with everything, because it could be 20 symptoms, but a lot of them overlap. But yes, it's a good way of managing.
And Nick also mentioned that he's, you know, do patients bring their medication list to clinic? I'm spending ages trying to get their meds lists and it's wasting time. I mean, we're very blessed, certainly for our Parkinson's Advanced Symptoms Unit. We have a pharmacist, Viv Horton, who will often print off the summary care record for every patient that's come into clinic that day. And that's
when we send out our clinic letters, we ask them to bring in their most recent prescription.
Yeah, I think summary care records. I love the summary care record though, because you can see when it was last issued. Yeah. You know, you can see all these other meds that you never even think about, like eye drops and things. Like I never know what to make of eye drops, but just there's often something you just go, oh, I didn't realize you were on that.
Well, we have something called a Welsh clinical portal, and we have that open in clinic, and that shows all the medication the patient's on with the GP.
Yeah. So there's a good question from Charlie about, in a dementia patient, if you're using Matapar dispersible, can it be thickened for oral intake if not administering via nasogastric tube?
No, you can thicken it.
Yeah.
You can thicken it.
It's worth remembering, because Anita, our nurse, blew my mind one time by telling me that all the granular stuff at the bottom of the glass isn't actually the active medication. It's a bit of inert tablet. So don't make a patient's throat perpetually gritty trying to get the last bits of the Matapar dispersible, because it's all in suspension quite quickly, isn't it?
Yeah, and the best tip is Cinemet dissolves even better.
Yeah,
and you can crush it between two spoons and give it with a spoonful of yogurt. It works very easily, so you don't always have to have the dispersible Matapar.
Yeah, that's a really good idea. Cinemet, it does make everything go yellow, but
yes.
Can we give medication for disabling tremor? One word answer: no. The tremor is impossible to treat. Sorry, that was a very flippant answer.
Yes.
Like there's a whole other lecture on that, but it's you're just, without deep brain stimulation, there's next to nothing that's very good at tremor. If you happen to be lucky to get your patient onto clozapine for some reason, their tremor tends to go away then. But
and some tremor responds very well to apomorphine pump.
Yes, that's true. And about 50% of them with if you get the levodopa up, but you have to be a wee bit careful with that. Let's see what else. Gait assessment when patients using a mobility aid. I think you can probably still see the gait hesitancy if you're getting them to turn. Harder, obviously, to see things like arm swing when they're kind of holding a mobility aid, of course. But you can still see the gait hesitancy freezing. You can still see persons struggling to get in and out of the chair. PIG subtype of Parkinson's versus PSP can be a challenge in your view, Raj, and in mine. And I think this posture instability, pure akinesia, gait freezing kind of PSP phenotype, which I think it accounts for most historical cases of vascular Parkinsonism. It's mostly that doesn't really exist, and it's mostly PSP or something else. And I feel like, that's a really difficult one. In practice, it doesn't matter because you're just going to use the same treatments. But I guess the conversations differ. And I think as long as you're open-minded to changing your diagnosis, which I perpetually have to do. Patients with an element of Parkinson's and normal pressure hydrocephalus, how different are the symptoms from idiopathic Parkinson's? I don't think I have any problem with normal pressure hydrocephalus and idiopathic Parkinson's bamboozling me. I have massive problems with normal pressure hydrocephalus mimicking PSP clinically because they have cognitive problems, bladder problems, and a very weird gait. And I find that very difficult. And at least 3 of my most recently shunted patients now all look like they've got PSP despite having what looked like NPH initially. So I think NPH is a real minefield. Don't feel bad about struggling with it. Because like me and Lou Wiblin up in Teesside, we just spend our entire life scratching our heads about NPH. And then the last question, any role for a DAT scan apart from differentiating Parkinson's from essential tremor and drug-induced Parkinsonism?
No, there isn't. That's the rationale for it. If you look at nice guidelines, isn't it?
Yeah, I mean, some that used a little bit in mental health services, obviously, to try and pull apart DLB and Alzheimer's.
Yeah.
Right. For similar reasons. So you can use it
Yeah.
for that. It's definitely not useful for follow-up.
No.
It is. And it's not that good a test. Like the studies, very pure studies with incredible neuroradiologists who are dyed-in-the-wool, DAT scan gurus. Their sensitivity specificities for DAT scans are amazing. But in the real world and recently in my clinical practice, I've had patients where I've not at all trusted it at all, and I find it really it can be difficult. I almost diagnosed Parkinson's as a 28-year-old 2 months ago because she had an abnormal DAT scan on 2 occasions. Didn't make any sense to me. I asked them to look back at the DAT scan again. They reprocessed the images. It was completely normal.
Oh gosh. And
I'd already done all her genetics for whatever, DJ1 and pink and all that kind of stuff. You have to be careful with DAT scans. I have to ask the right question, because if you're doing them for the wrong reason, you'll struggle. There was one more question. We could be here all day answering questions. Like, I feel like probably we should. I'm really sorry. If I have 5 minutes, I might try and type an answer to those last 2, if that's all right.
That would be perfect, Archie. Thank you very much. Louise and Archie, thank you very much. That was brilliant. Daniel commented that he's enjoying this different approach to the webinar. So well done. And Susanna said you've validated twice her own practice in her area. So thank you for validating people and making them feel so much better about this.